Your environment is out to get you. That's right. Your surroundings can trash your senses, your sight, hearing, your sense of smell and breathing. Okay, maybe that's laying it on a little thick. Your surroundings can get you if you don't pay attention or take precautions. It's hard enough as adults to maintain the right level of situational awareness each day in every context we find ourselves, at work, at home, in public. Children are especially vulnerable to environmental injuries for many reasons: anatomic, physiologic, and behavioral. Today, we'll see just how children are different and how we can evaluate and help them when they come to us to keep their senses from getting trashed. Look, listen, smell, and breathe next on the Playbook.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Children experience their environment differently. Whether we're talking about body surface area, metabolic rates, behaviors, or whatever, there are some specific differences we should be aware of when we're evaluating a child with an environmental exposure. First, children have higher respiratory rates. What's a normal respiratory rate for a child? In a newborn to young infant, 30 to 40 breaths per minute. An older infant or toddler, 20 to 30. Young school-aged children, maybe 20s or so, and school-aged children in the teens. In adults, a normal respiratory rate is, 10 or 12, maybe 16. I know the nurses lovingly chart the generic 20, right? Which in an adult is WNL, within normal limits, or more like we never looked. When you think about it, for an adult, 20 is pretty fast in reality. Your respiratory rate is only half of the picture in respiration. Minute ventilation, or minute volume, is your respiratory rate times your tidal volume, the amount of air you take in with a normal breath at rest. So, respiratory rate times tidal volume is minute ventilation, how much air you move in a minute. A normal non-forced breath in an adult will pull in, 40 mLs, 450, maybe 500 mLs per breath. If we were to do the math, now stick with me here, 12 breaths per minute times 500 mLs per breath gives you 6 liters per minute, which fits in nicely to the typical adult minute volume of 5 to 8 liters per minute. So far, so good. As we mentioned in children, respiratory rates vary. Let's consider Harvey, who is a 10-kilogram, 1-year-old boy. He's respiring at 30 breaths per minute. All normal. Tidal volume in awake, spontaneously breathing people is typically 7 mLs per kilogram. Harvey is 10 kilos, so his tidal volume will be 10 kilograms times 7 mLs per kilogram, so only 70 mLs per breath. Doesn't seem like much. When you visualize it, it's the volume you would get out of 2 large chicken eggs. Okay, the tidal volume is only 70 mLs per breath. The minute volume is a little more striking. Harvey breathes at 30 per minute, so tidal volume times respiratory rate is 70 mLs times 30 breaths per minute. That gives Harvey a minute ventilation of 2,100 mLs per minute, or 2.1 liters per minute. Okay, I realize that the adult minute volume of 6 liters per minute is larger than the typical minute volume of 2.1 liters per minute. But if we compare the minute ventilation to body mass, Harvey wins. Pound for pound, or kilo for kilo, the 70-kilo adult who has a normal tidal volume of 6 liters per minute ventilates at 85 mLs per kilo per minute. I just took the tidal volume over the weight, so 6,000 mLs per minute per 70 kilograms equals 85 mLs per kilogram per minute for the adult. Let's see how much ambient air Harvey processes in a minute in relative proportion to his size. He's 10 kilos. His tidal volume is 70 mLs, so his minute ventilation, we said, was 2,100 mLs per minute. If you take Harvey's minute ventilation in relation to his little 10-kilogram body, he ends up breathing in and out 210 mLs per kilo per minute, more than double that of the adult. Not because of tidal volume, but because of rate. In a pure, clean, perfect environment, this would be just another math exercise. But when we talk about possible airborne exposures, like smoke or solvents or particulates, or even industrial accidents or chemical weapons, the small child processes much more of his environment than the adult does. Pound for pound, kilo for kilo, he is exposed more to his environment because his lungs process the ambient air more for his body size. Take this information into consideration when you're seeing a family who had a smoke exposure, for example. The adults may be doing relatively well, but the little ones may be suffering in silence. A recent international incident was an example of how children can be much more affected than adults. In 2013, the Syrian army used chemical weapons supplied by Russia on cities like Damascus. When the Assad regime released sarin, a nerve gas, on civilians, adults were affected, but children died in large numbers, in most part because the ml per minute per kilogram of ambient air moved by those little lungs. Children have a larger body surface area to mass ratio. If we were playing blocks in the nursery and we had to choose avatar shapes for ourselves, then maybe you could see that children are more like little spheres than their adult counterparts, who are more like cylinders. This comes into play later when we talk about heat radiation. More than 2,000 years ago, Archimedes discovered that the surface area of a sphere is the same as the lateral surface area of a cylinder if they share the same radius, and length of the cylinder is the diameter of the sphere. So we're now talking about two shapes with the same surface area, but different volumes, or in this case, in human beings, masses. The sphere only holds so much, while the cylinder can accommodate more. Consider the Star Wars characters C-3PO and BB-8. BB-8 is our adorable roly-poly robot droid who radiates joy and fun. C-3PO is our older, more cylindrical-shaped curmudgeon. Their surface areas are the same, but BB-8's body mass is half that of C-3PO's. It's the shape that allows for less mass in BB-8, and by extension, our roly-poly toddlers. All of this is because surface area is two-dimensional, but volume is three-dimensional. As you get older, your volume or mass increases more rapidly than your surface area. From a purely physical science perspective, we grow into our proportions from childhood to adulthood. Just to illustrate further, a 3-year-old is typically 3 feet high, weighing 15 kilograms. He is half as tall as a 6-foot man who weighs 80 kilograms. The child is much lighter for his height than the adult. This also means that children can lose heat much more easily than in adults. And the inverse is true as well. They have more of a surface area to absorb toxins per kilogram weight. This becomes an issue with hypothermia, hyperthermia, and toxic topical agents. Children have higher metabolic rates than adults. We can't talk about metabolism without talking about circulation. Cardiac output is the volume of blood that the left ventricle pumps per minute. So, stroke volume times heart rate. Small children can't increase their cardiac output by normal Starling forces. They can't increase their contractility. They can only increase their heart rate. Stroke volume in young children is relatively fixed. Cardiac output is increased by increasing heart rate. So this is why unexplained tachycardia is such a red flag in children. Cardiac output in liters per minute is a very generic measurement. A typical cardiac output in the 70 kilogram adult with no medical issues is 5 to 6 liters per minute at rest. A newborn may have a cardiac output of only 0.8 liters per minute, mostly because his stroke volume is only 5 mLs. Compare that to the adult whose stroke volume is 100 mLs. The issue is that cardiac output as a measurement of circulation and, by extension, metabolism only works for the textbook reference 70 kilo adult. But we don't treat skinny mannequins here. We treat people of all sizes and shapes. A more universal measurement is the cardiac index. It's your cardiac output by your body surface area. Having a measurement relative to the body surface area helps to compare apples to oranges to mandarins. In other words, cardiac index is cardiac output divided by body surface area. It takes your size into consideration. Now the fun begins. An adult has an impressive cardiac output of, say, 6 liters per minute and an equally impressive cardiac index of 1.5 liters per minute per meter squared. Here is where the child outshines the adult. Children are so hypermetabolic that when you correct their cardiac output for their size, that is, you look at their cardiac index, it's a whopping 3 to 5 liters per minute per meter squared. Again, adult cardiac output corrected for size is cardiac index 1.5 liters per minute per meter squared. Cardiac index in the child, because of his higher metabolism and heart rate, is 3 to 5 liters per minute per meter squared. This means that the child's organs will have more efficient access to nutrients, all good things, help them grow nice and big and strong, but also more efficient access to toxins that they are exposed to. Their macro machinery is speeding along. On a micro level, children's basal metabolic rates are also relatively high. The basal metabolic rate is the rate of energy expenditure in a given amount of time at rest. It increases rapidly with the rapid growth we see in infancy and early toddlerhood, then meets adult levels in the later teenage years. Both of these factors, the cardiac index on the macro level and the BMR on the micro level, drive how children metabolize medications, how they chew up benzos like it's candy, or how vulnerable they are to hypoxia. Or when they come into contact with a toxin, it's readily absorbed before you can even stop the exposure. Another factor that puts young children at risk for environmental exposures is a fragile network of blood vessels in the brain. Historically, we were all taught that the baby's blood-brain barrier is immature until approximately 4 months of age. The latest thinking is that the actual tight junctions are, in fact, functional. During development, tight junctions between cerebral endothelial cells are functionally effective as soon as the first blood vessels penetrate the parenchyma of the developing brain. The more nuanced view now is that what we called generically the blood-brain barrier is in itself functional, but the developing cerebral vessels themselves are more fragile than previously understood. The blood vessels themselves are not as weather-ready as they are in adults. The young child's efficient circulatory system carries these toxins over and over again to these fragile cerebral vessels and makes the brain parenchyma in the developing brain more vulnerable to toxins. Thin skin. Children have very thin skin and very permeable skin. Their desmosomes are looser. They have a looser stratum corneum. Their skin is about 1/5 of the thickness of that of an adult. This sets them up for vulnerability when we talk about topical agents. For example, right now, it feels like everyone has a fever. A home remedy that many people have is to use rubbing alcohol. It's used because it feels like it's a cooling agent. It evaporates at a lower temperature than body temperature. The flash point is the temperature that a liquid spontaneously becomes a gas. Water's boiling point is its flash point, so 100 degrees Celsius. Isopropyl alcohol has a flash point of 11 Celsius or 53 degrees Fahrenheit. That means the moment it touches your skin, it feels cool. It's already evaporating from your skin's surface. It's a folk remedy used in many traditions. For adults, it usually ends up being fine, but there are case reports of adults suffering from isopropyl alcohol poisoning because of repeated usage of topical alcohols. For children, topical alcohol, especially isopropyl alcohol, is a big no-no. Under no circumstances should we be using rubbing alcohol for children as a cooling agent. First, it doesn't actually cool you down, you just feel transiently cooler. Secondly, when absorbed through this thin skin, it will result in altered mental status, respiratory depression, vasodilation, hypotension, and hypoglycemia. Of course, if this were a teenager ingesting it, it could cause hemorrhagic gastritis. There is no established safe topical dose in children. Over the counter, you can get 70% or 91% isopropyl alcohol. Even 99% is available over the internets. I just had a talk with a mother of a young toddler. She brought him in because she said, well, every time he has a fever, I bring him in. Just want him to get him checked out. She wasn't particularly worried, and he ended up having a benign viral syndrome. But when I asked about how she was caring for him at home, she proudly told me all about her soups. Okay, good. Her antipyretics. Okay, I like where this is going. And was especially proud of her using rubbing alcohol on him. I listened carefully and praised her for all of the great things she was doing, and then kindly but firmly asked her to stop, please stop using rubbing alcohol. I say carefully because as a family remedy, there's a lot of pride instilled in there. I don't want to infringe on that, but I do want to redirect and keep the child safe. After initially bristling a little bit over it, she did understand. Taking the time to make that connection was worth it. If I had brushed her off on this one particularly nostalgic issue, she may have brushed off all of our precautionary advice and safe home care, turning this visit into something that was essentially useless. I tell you this really to give an example of why it's important to ask what is going on at home. Our detective skills can be used for diagnosis, but also for safe precautionary advice. Proximity and behaviors. Young children are low down to the ground. They're on the floor. They're curious. They have all the time in the world. And they have an oral fixation. That is a recipe for disaster if the environment is not secure. Whenever I see a young child who may have come in after a choking episode or ingesting something, or really any time I'm worried about the home situation, at the end of the visit, I give my friendly precautionary advice. Mom and Dad, get down on their level. See what they see. Crawl on the floor with them. Look to see what they can only see from their vantage point. Auntie may not have visited in a month or two, but maybe one of her glipizide pills fell down and rolled behind the couch, just out of reach of the broom or the vacuum, but not out of reach for Johnny's fast little fingers. So, children are more vulnerable to environmental injuries because of their higher respiratory rate, higher metabolic rate, thin skin, fragile cerebral vessels, and their signature proximity and behaviors. Now that we have that down, let's give an example of how each of your senses, look, listen, and smell, can get trashed by the environment when you're a young child. Look. Ultraviolet keratitis is something that's often overlooked. You don't have to live near the equator to experience this. Snow blindness is another term for UV keratitis. Basically, it's a sunburn of your eyes. Sometimes it's obvious that a patient was exposed. You get a history that they were out all day in the sun or in the snow without eye protection, or they complain of eye pain and also have a sunburn on their face. Another overlooked source of unsafe UV light is a damaged halide lamp. You've seen these before. They are the ultra-bright industrial lamps that we use in gymnasiums or sporting arenas or parking lots, anywhere you need flood lighting. The halide lamp is bright because the electric arc passes through vaporized mercury or metal halides, which are just compounds that contain bromine or iodine. Incidentally, they can be found in homes, in fish tanks, for example. Anyway, the lamp gives off intense visible light as well as intense UV light. Each lamp has an outer glass envelope that attenuates and hopefully mostly blocks that invisible UV light, but it also allows the visible light, of course, to shine through. So extremely bright and effective and safe as long as that outer glass envelope isn't damaged or cracked or blackened. But it may just have a tiny crack in it because of a stray ball that hit it from a stadium, and we wouldn't know otherwise until the damage is done. Like any sunburn, you may not realize it as it's happening, only when it's too late and the pain sets in. On exam, you'll see a patient in a lot of pain. Give some topical anesthetic drops so you can get a better exam. You'll see conjunctival injection and possibly chemosis or fluid under the conjunctiva. In severe cases, the cornea may appear slightly hazy from the burn. On fluorescein exam, you'll see pathognomonic punctate small pits in the cornea. You may also see erythema of the face and lids. Visual acuity is typically mild to moderately reduced, but it may be difficult to figure out what the visual acuity is because it just hurts so much. use that topical anesthetic to try to take a little bit of the cream off the top. Treatment is mostly supportive. This is a very painful condition, and oral opioids may be what you need to get that little patient to cope. We often hesitate to give children opioids for some reason, but there are times when opioids are very much indicated, like in UV keratitis. Antibiotics are not necessary per se, but giving an antibiotic ointment can lubricate, soothe, and discourage superinfection. So just go for it. Listen. Barotrauma to the tympanic membrane can happen from loud noises, when airbags are deployed in a motor vehicle collision, or really any time there's a sudden change in air pressure. Your little patient may just complain of ear fullness, or pain, or loss of hearing. So you look and there's no wax, so that can't be it. The TM is not bulging, it's not fluid filled, so not an infection. So, what could it be? Well, asking a few more questions may get you to the diagnosis. A motor vehicle collision is usually pretty easy to get to. Patients will let you know that if that's the context, they'll tell you I was just in an accident, but maybe they were just at a sporting event, or a concert, or around noisy machinery, or firecrackers. When thinking about TM barotrauma, we should consider 3 factors: decibels, distance, and duration. The modern world is full of noise, and our ears were just not designed for it. Babies shouldn't be around any sounds louder than 60 decibels, which is just normal conversation. Loud sounds like traffic or alarms are in the 70 to 80 decibel range. Very loud sounds include power tools or other equipment in the 90 to 110 decibel range. The painful range is about 120 to 140 decibels, which includes fireworks or guns. The World Health Organization recommends that the episodic max decibel level for adults is 140 decibels, and for children lower, 120 decibels. Which brings us to distance. Even lower decibel ranges can be harmful if the sound is just too close to that little eardrum. The intensity of the sound blast is inversely proportional to the square of the distance. Conversely, if the sound is very loud, it's imperative that the child be kept at a safe distance. Fireworks, for example, can produce up to 170 decibels of sound pressure. A safe distance, quote unquote, for adults is considered to be 50 feet or 15 meters away from the source of the sound. And children, they should be 200 feet away or 60 meters away from this. So that's decibels, distance, and now duration. Faint sounds, like a normal conversation, can go on indefinitely without hearing loss or TM damage. More than 8 hours of constant traffic in the 70 to 80 decibel range, loud range, can cause some hearing loss or membrane injury. An hour of being near power tools without protection puts you in the 90 decibel range, or very loud. And the painful range of 120 to 140 decibels, we should only be transiently exposed, so less than 2 seconds. Well, why is this? Why are children more affected by noise? Well, it's all about the physics of sound. Do you remember the last time you were driving and you just had the driver's side window cracked open? Do you remember reaching to open another window fast because there was that buzzing, irritating sound? Your ears hurt you. That is the Helmholtz resonance. This happens when air travels faster over the opening of another air-filled container. You see where I'm going with this? The Helmholtz phenomenon is how flautists can use a perfect embouchure to blow air over the lip piece and play the flute beautifully, or when you're just having fun and playing the perfect low note over an open bottle. Adult external auditory canals are relatively patent and larger, and so air traveling past the auricle doesn't cause that much resonance to the air-filled space in the canal. A child has a tiny and sometimes floppy external auditory meatus in comparison. Lots of energy transmitted into that canal and reverberated off the eardrum. Loud noises simply hurt little children more. So, back to our school-age child who complains of ear pain, but there's no wax, the TM doesn't look infected. Look again. Is it a little red? Or a little retracted? Or maybe just normal? What's that you say? You were at a friend's house and he was playing with firecrackers. Well, that might be it. You may also see perforation. The TM will heal about 1 millimeter in diameter per week. So often children should have perforation precautions for 1 to 2 months after diagnosis. That means no head submersion, no drops in the ears. Be careful with vigorous nose blowing. Antibiotics for just barotrauma aren't needed. And air travel is completely safe with a perforated eardrum. Watchful waiting is the norm, and any primary care physician can manage this if follow-up is even needed. You may consider referral to the ear, nose, and throat surgeons if there are prolonged symptoms or the perforation is extensive. If relatively small, they can do what's called a paper patch laryngoplasty in the office. They literally patch up the defect with a piece of medical-grade paper. More extensive damage can be treated non-urgently in the operating room with a formal tympanoplasty. The healing process takes time because, you can't cast an eardrum, you can't staple it, you can't immobilize it, you can't splint it. It's being used all the time, healing and working. Sound familiar? Smell. Sudden anosmia is relatively rare in children and mostly an infectious phenomenon. In adults, we also think of industrial exposures. I'm going to use this to stretch the paradigm a little bit of trashing the senses and include undersmell your whole breathing apparatus. So let's talk about smoke inhalation. It affects children much more than adults for many reasons, most of which are anatomic. An enclosed fire heats dry air rapidly, which can precipitate the glottic reflex. The glottis closes, the patient passes out, but there's little to no lower airway damage. If the enclosed space includes a good amount of steam, the humid, heated air can be inspired deeply and cause direct injury to the lung parenchyma. Getting some sense of the fire, its characteristics from our EMS colleagues can really be helpful here. Of course, if you hear stridor or hoarseness, or see a facial burn, or see soot in the nares, any labored breathing or impaired gas exchange, optimize them, give them oxygen by non-rebreather face mask, and take over that airway. It is growing more edematous as we speak. Just to illustrate the range of airways you'll see, the narrowest part of the child's airway is below the vocal cords. For your medical educational entertainment, I give you airways as drinking straws by age. In newborns and young infants, the narrowest part of the airway is the size of a standard drinking straw, or 6 millimeters. As a toddler, your narrowest airway diameter is that of a smoothie straw, or 9 millimeters. When you're a school-age child, you get up to the size of a boba straw, or 12 millimeters. Adult women have a tracheal size of about 20 millimeters and men about 25 millimeters. You can use a literal rule of thumb here. Your trachea size is roughly the diameter of your own thumb. So let's do a little math. Let's take a 3-month-old who was rescued from a house fire. The child seems relatively okay when you see her in the ED, but you start to wonder. The narrowest part of her airway is going to be the standard size of a straw, 6 millimeters. The area of a circle is pi r squared. So let's plug in 3 millimeters for the radius, and you get an area of 28 millimeters squared. Just 1 millimeter of edema or secretion or soot or anything, that 1 millimeter will change the radius from 3 millimeters to 2 millimeters, and the area to 12.5 millimeters squared. That 1 millimeter of edema took the airway from 28 millimeters squared to 12.5 millimeters squared. That is over a 50% reduction in area. Whether we're talking environmental soot or we're talking RSV waterfalls, a small difference in diameter or radius will make a huge difference in area. When talking to parents, even with a benign cold, I'll often use the patient's fingers as a reference point to show them how much nasal suction can really help with. If you think about it, when you're an adult, you only really inspire 10% of your normal breath through your nose. As a young infant, 100% of your air is going through your nose, of your normal breaths. This is why we call them obligate nasal breathers. Okay, area is just a static measurement. What we really care about is airway resistance. Resistance is pressure over flow. Another way to arrange the equation is resistance is a bunch of math over the radius to the 4th power. So tiny changes in the radius in the denominator will increase the resistance exponentially. That same 1 millimeter of edema, when plugged into that equation, will increase the airway resistance by 16 times. So, if the debris or edema is from an environmental agent, then get ready to intubate. If it's from RSV, then suction, suction, suction. Your airways and their resistance will thank you. To summarize, children sometimes take a back seat when there is an environmental emergency, only because the adults will definitely be more vocal and the severity of illness in children may not be readily recognized. Their anatomy and physiology make them vulnerable. They have a higher respiratory rate. They have higher metabolic rates, thin skin, fragile cerebral vessels, all added to their signature proximity and behaviors. The next time you see a child who may have had an environmental exposure, ask your usual really great detective-style questions and take a moment to observe. They just may be sicker than previously thought. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.